You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for February 20th, 2026. This week, longer-term data in the EVOLUT Low Risk TAVR trial, a provocative meta-analysis, DNR, targeted hypothermia, good news in HFpEF evidence, GLP-1 agents as AFib drugs, and the evaluation of patients with chest pain. There was big news in the TAVR versus SAVR in low-risk patients this week. Jack published 6-year outcomes of the EVOLUT Low Risk trial, and there were surprises. Now, recall that the EVOLUT Low Risk was first published in the New England Journal of Medicine in 2019. This had 1,468 patients with severe AS, and they were randomized to the self-expanding Medtronic TAVR valve versus surgical AVR. This study had a non-inferiority design with a primary endpoint of death or disabling stroke at 2 years, and it was analyzed with Bayesian methods. The trial found a greater than 99% probability that TAVR was non-inferior to surgical AVR or SAVR. Now, many trials have shown similar outcomes for TAVR versus SAVR at 2 years. Low surgical risk patients, though, want to know about longer duration outcomes, including the valve reliability and the intervention or reintervention rate. Now, before I say anything about the results, I have to say that both the balloon expandable and self-expanding trialists have been excellent about reporting longer-term outcomes. I mean, other than the Partner 3's mysterious change of primary endpoint, the entire evidence landscape of TAVR versus surgical AVR has been pretty exemplary. All right, the main results of this 6-year trial. The primary composite endpoint continued to be death or disabling stroke. However, changed is that the trialists no longer analyze by Bayesian methods, and they no longer use non-inferiority. Now, the analysis is superiority using Kaplan-Meier estimates. And the composite of all-cause mortality or disabling stroke was 23.3% for TAVR versus 20.4% for surgery. That difference was 2.8 percentage points higher for TAVR. This fairly large absolute risk increase did not come close, however, to reaching statistical significance. The p-value calculates at 0.43. At this 6-year report, many of the patients had 7-year outcomes, and at 7 years, with a vital status sweep, the mortality rates were more divergent. 27.7% for TAVR, 23.9% for SAVR. Cardiovascular mortality was essentially identical between the groups, 11.1 versus 11.0%. A major point of emphasis and a new finding came when they looked at reintervention rates, which were similar at 5 years but divergent in years 6 or 7. Namely, cumulative reintervention rates were 5.5% versus 3.3% at 6 years. That p-value was 0.07. And it rose to 9.8% reintervention TAVR, 6.0 reintervention surgery at 7 years. Now that p-value is 0.02 in favor of surgery. Now I know that you could easily gloss over the medical jargon reintervention, but I would not. Why? Because reintervention for TAVR can be quite serious, especially if it is surgical, as it was in 2/3 of the reoperations in this trial. Because observational data have shown death rates as high as 13% when you have to operate or cut out a TAVR valve and replace it with a surgical valve. Now, the reintervention death rates were only 3.3% in this trial, but these were low-risk patients and these were highly skilled operators. In other words, I guess I'm just saying that reintervention in TAVR is a really serious outcome. Now, the causes of reintervention are important. The rates of intervention for aortic stenosis of the bioprosthetic valve was similar in the two groups, but more patients in the TAVR arm had reintervention for aortic insufficiency than those in the SAVR arm, and that could be important because AS tends to be slow and AI might be more acute. Now, seemingly perplexed by the higher reintervention rates, the authors did an exploratory analysis looking at the use of something called post-deployment balloon dilatation using a balloon larger than the valve waist. This they termed off-guidance post-dilatation. And this exploratory analysis showed us just barely significantly higher rate of reintervention in patients who had off-guidance dilatation. And so the proponents could say, aha, just don't do off-guidance dilatation and all will be good. But I guess I would caution against this sort of thinking because A, the association could be noise, wasn't that significant, and B, doctors aren't doing dilatation willy-nilly, right? They do it because they see a potential problem like non-ideal valve expansion or maybe a paravalvular leak, and so there could be reverse causality or confounding. It might not be the off-guidance post-dilatation. It might be the reason that they were doing off-guidance post-dilatation. Now, there's also a suggestion that older evolute valve types may be causal in these reintervention rates, and newer iterations may be better, but of course, we don't have 6-year data on these newer valves. So my comments on this whole thing from a neutral perspective, the first thing to say is that we've got to take the view of a patient, right? Even if a TAVI is 1 or 2 or 3% worse at 10 years, I think some rational people might favor the substantially less invasive procedure. I mean, it takes months to recover from open heart surgery, so there is that. But many 65 or 70-year-old patients with AS would care what happens when they get close to 80 years old. A substantial difference in mortality would be something that many people would consider really important in their decision. Now, the other thing to say or to start with is that TAVRs may be similar to PFA in that not all TAVRs are the same, right? The higher reinnervation rates seen with EVOLUT in this trial have not been seen with balloon expandable valves. But, not only is the reintervention worrisome, the death signal also looks worrisome to me. I mean, it's 3% higher death rate. Now, I don't really think you should ignore a nearly 3% higher rate of death in the TAVR arm. Now, Dr. David Cohn pointed out online to me that a p-value of 0.4 suggests it is not surprising given a null hypothesis of no difference. But I would counter that by saying that a typical analysis of Kaplan-Meier curves requires something called proportional hazards over time. And this is not the case in these trials. As the Kaplan-Meier curves cross, there's early TAVI benefit and it changes to a later hazard. And this means that there are non-proportional hazards. Now, I know this sounds like gibberish, right? But it is not kind of gibberish. And how do I know that? Because the same journal, JACC, has published a review article discussing the problems and analytical solutions for non-proportional hazards, and I'll link to that. The second issue I have with the higher death rates in the TAVR arm is that the original EVOLUT trial used a non-inferiority design with a non-inferiority margin of 6%, which seems kind of high to me, but nonetheless, 6%. Starting with the 3-year analysis, and I'll link to all these papers, the authors changed to a superiority testing strategy. I could not find anywhere where that was pre-specified. Now, at 7 years, the authors write in the discussion section that, quote, there are no significant differences were observed between the treatment arms for all-cause mortality. But listen to the numbers. 27.7% TAVR, 23.9% surgery. Now the difference in higher death rate is 3.7%. The 95% confidence interval goes from minus 2.4% to 9.9%. The p-value is still not anywhere close to significant, but the upper bound is 9.9% worse. That's well larger than the 6% non-inferiority margin. Not only that, but something is changing over time in these mortality curves. If you combine reports of death from the 4-year EVOLUT paper to this paper, here's what you get. The TAVR mortality goes from 9% to 27.7%. That's an increase of 18.7%. The SAVR mortality goes from 12.1 to 23.9%, and so SAVR mortality is only increased by 11.8%. I wonder, had the authors stayed with their Bayesian design, what would the probability of TAVR having a higher death rate at 6 or 7 years? I don't know. I suspect it would be pretty high. Now, you think I'm being too harsh on TAVR. Well, What about the recently published BMJ Heart meta-analysis, first author Marin Quartas et al.? This was updated 5-year outcomes of TAVR versus SAVR in low to intermediate risk patients, and I'll link to that. It's open access in Heart. They meta-analyzed 6 trials in about 7,400 patients, and they found that the relative risk for all-cause mortality was 1.12, and the credible intervals went from 1.02 to 1.22 with no heterogeneity. That's a 99.3% posterior probability that SAVR was superior to TAVR for the endpoint of mortality at 5 years. For stroke, the median relative risk was 1.13. The credible interval went from 0.93 to 1.39 with very little heterogeneity, and that resulted in an 88.0 posterior probability that SAVR outperformed TAVR for stroke outcomes. Now, proponents of TAVR may argue that a 2025 meta-analysis, first author Rohin Reddy, and I'll link to that, in JACC found 5-year results better for TAVR. Yet that meta-analysis weighted trials with shorter results, specifically the Dedicated and EVOLUT 4-year trials. Now, one final thought. The UK TAVI trial was a pragmatic randomized trial comparing TAVR to SAVR in low-risk patients in the UK. The 1-year results were favorable for TAVR, and it was published in JAMA, and I'll link to that. The 5-year results were presented during EuroPCR in May of 25. The results were far less favorable for TAVR. This report found a statistically significant and clinically relevant increase in stroke in TAVR patients, 12.9 versus 7.3%. That p-value was 0.01. And again, in the UK TAVI 5-year results, there was a numerically increased mortality in TAVR patients. It's now February of 2026, 11 months later, and the data has not been published. In sum, my comments on TAVR remain the same. It's an amazing procedure for high-risk patients with AS. It's probably a very good procedure for intermediate-risk patients. But for low-risk patients, I have concerns over valve reliability, reintervention, and higher stroke rates. Now, the investigators get credit because they're presenting this data, but I have to say the curve crossing is worrisome. A young patient with aortic stenosis needs to know this information because it's relevant to their shared decision-making. All right, next topic, briefly. What about DNR in the hospital? Well, I came across a really interesting viewpoint paper in JAMA on documentation of, get this, unilateral DNR orders, which I did not know existed. Now, normal practice or a standard DNR is requested and agreed on by the patient or the patient's surrogate. Yet, there are many cases when clinicians know that CPR is not only futile, but also totally inappropriate clinically. In this case, I learned from this editorial from Drs. Piscitello, DiMartino, and Parker that a unilateral DNR can be placed. A unilateral DNR is a DNR order that does not require a patient or a surrogate consent. This is indeed an area of medical ethics controversy. The most obvious reason for such an order is that CPR, which is a medical intervention, is felt to be contraindicated, in the same way that an ablation or heart catheterization or PCI would be contraindicated. I also learned that clinicians often document unilateral DNR decisions by placing a standard DNR order in the electronic health record, rendering them indistinguishable from a DNR order entered when a patient or surrogate requests to not receive CPR. The 3 authors argue that this is unethical because it obscures the unilateral aspect of the decision. They have a nice figure in their paper about the types of DNR, specifically the unidirectional DNR, where there is conflict from the patient surrogate who wants CPR and when the patient surrogate assents to no CPR more covertly. When there is conflict, the authors argue this is clearly a unidirectional DNR. However, the authors note the more common type of unidirectional DNR is just a covert DNR. Let me quote from their writing. Quote, an assent unidirectional DNR decision occurs when a clinician makes a unidirectional DNR decision and the patient or surrogate disagrees with the decision but either does not express disagreement, does not demand CPR, or has a preference to receive CPR but chooses to defer to clinical decision-making. So one of the main thrusts of this short editorial is that currently there is poor documentation of unilateral DNR orders, and these could contribute to inconsistencies in patient care. For instance, the authors write that the lack of awareness that a DNR order was a unilateral clinical decision decreases the likelihood that clinicians will reevaluate that order for patients whose clinical condition improves. I actually had a similar situation occur to me when a patient with VT storm decided that she did not want any more CPR. Things were really bad, and it was a good decision. But then the VT stopped, and 2 months later, a doctor called me and said, "John, this patient shouldn't be DNR," and we agreed and we changed. The authors call for hospital systems to create and implement a unidirectional DNR order that's unique from a standard DNR. This type of order, this unidirectional DNR, should include specifications within the order that require clinicians to regularly reevaluate the code status if the patient clinically improves, and is to designate whether patient or surrogate disagreement exists with the order. Now, one consequence, they write, of such a visible policy would be to increase visibility of these unidirectional DNR decisions and potentially normalize use of unidirectional DNR decisions and influence clinicians to more regularly invoke this mechanism. Now, I highlight this important piece and topic because one of the greatest stresses I have in the hospital is contributing to bad deaths. Interventional cardiologists like EPs and others are often put into this situation because events like MIs, heart block, or VT are often signals of a dying patient. We see someone who has no chance of meaningful survival from our interventions, and further resuscitation is not only not beneficial but directly harmful, and we hope that a family discussion goes well and that we are allowed to provide comfort in the dying process. But at times there is no family, or the family is unsure, and there's a need for some sort of unilateral DNR orders. I don't think I've ever come across a direct conflict with a patient, but surely we all have had some degree of assent or covert unilateral DNR. But, I don't really see the ethical tension in this. Do you? If you do see tension, one example I took from a nice discussion the authors had on the Jerry Powell blog, and I'll link to that, was that when we do CPR, when we're actually doing the 20 to 30 minute procedure and it isn't working, there comes a time when a clinician decides to stop. That's a pure clinical decision. And I don't really see that as any different from not beginning CPR in the first place. There are days when I feel my greatest contribution to patient care that day is helping a patient and a family get a DNR order so as to avoid harmful end-of-life care in that person. All right, next topic is yet another failure of targeted hypothermia in the ICU. I'm sorry, and I'm going to keep this brief because I am triggered by the fact that for years, my ACLS module kept forcing me to go against the mountain of evidence against targeted hypothermia in survivors of out-of-hospital cardiac arrest. We are better now at not doing this, but cooling patients who survived cardiac arrest persisted well after multiple trials found no benefit. I've written about it, I've podcasted about it, I've tweeted about it, and no one seemed to care. It does not get any attention. So cooling continued, and when I asked about it in the ICU, it was like asking about not giving the patient clean air and water. Well, JAMA Neurology has 2-year follow-up from an RCT called the TTM2 trial. Recall that the original publication of TTM2 was in the New England Journal of Medicine in 2021, and I'll link to that. This was 1,850 patients who were randomized to a target of 33 degrees hypothermia or targeted normothermia with early treatment of fever. And they found no differences in mortality at 6 months, a hazard ratio 1.04, and no differences in poor functional outcomes at 6 months. The JAMA Neurology paper looked at 2-year outcomes in the 84% of patients who had follow-up. And again, there were no differences in any 4 measures of neurologic outcome, which strongly suggests there was no long-term benefits either. I just wonder how much money we wasted and how many patients were harmed by aggressive cooling over the decade or so that it was done. Okay, let's do good news. Good news in HFpEF Evidence. Heart failure cardiologist and nice guy Ryan Tedford posted on X News of a trial design and rationale paper for a device called the Aperture Transcatheter Shunt System. Of course, I had no idea what this is, but I read about it, and it's amazing. Apparently, the device is a left atrial to CS shunt, and the paragraph describing the procedure in the rationale paper really made me smile because I thought, my gosh, these interventionalists are crazy. Get this. You go into the right in IJ, you go into the CS, distal CS, inflate a balloon, then a wire and a needle that puts a wire into the left atrium from the CS, so you're puncturing. Then you balloon the hole between the CS and the left atrium. Then you place this shunt catheter, which then stays there to shunt LA volume to the CS and the RA. This is shocking in its bioengineering. I have no idea if it will work. I seriously doubt it will work. But if you were a proponent and you wanted to show that it works, you would do it in the sort of triluminate way. That you would do a trial comparing people who had this shunt to a group that got white tablets, and then you would measure quality of life. But thankfully, and the reason why I highlight this paper is that's not what the ALT-FLOW 2 trialists are going to do. Not at all. This trial will include a sham control arm with blinding of patients and doctors. And this is why I highlight this rationale and design paper. The only way to assess subjective endpoints from procedures like this, including even our procedure, AF ablation, is to do it with proper sham controls. So I say congratulations to the trialist, the first author, Dean Kariakis from nearby Christ Hospital in Cincinnati, Ohio. Okay, next topic, GLP-1 as AF drugs. The journal Europace has an observational study worth thinking about. It's from the big EP group in Milan, Italy. They did a single-center, propensity-matched study of obese patients, BMI greater than 30, who had first-time catheter ablation for PAF between 2019 and 2024. One group initiated semaglutide within 3 months before or 1 month after ablation versus matched controls who did not receive any GLP-1 therapy. All patients had loop recorders, which is good. The primary outcome was AF beyond the 2-month blanking period. The final cohort included 181 semaglutide-treated patients versus 181 controls, and they were matched clinical and procedural characteristics. At 18 months follow-up, freedom from recurrence of AFib was 80% in the semaglutide arm versus 65.2%, and that was a hazard ratio of 0.52 and highly statistically significant. And of course, weight and BMI decreased significantly in the semaglutide group. And a substantial portion of GLP-1 treated patients achieved greater than 10% weight loss. So my comments. Methodologically, this is about as weak as it gets, right? It's single center, it's non-randomized, it's non-blinded. I mean, the loop recorders are a positive because it detects all AFib, but otherwise this is very low-level evidence. But I highlight it because we know that weight loss is strongly associated, if not causal, in improving AF outcomes in patients who have obesity. We know that weight loss improves left atrial structure and electrical properties. We know that weight loss improves blood pressure and glycemic control, which also have positive effects on the LA function and structure. So the findings are totally mechanistically plausible. This week, I met the Novo Nordisk representatives in town who made rounds in our office because oral semaglutide is now available. I have yet to prescribe these drugs. We were hesitant like this with the SGLT2 drugs because they were felt to be the realm of diabetes doctors. But then it became clear that SGLT drugs were cardiac and renal drugs, and I think we're at the same place with the GLP-1 drugs. It's time. And I am optimistic that GLP-1 drugs may become one of the best AFib drugs ever developed. It's surely going to be better than dronedarone or sotalol or amiodarone. That's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like the podcast, take the time to give us a rating, write us a review, and by all means, if you don't agree with something I said, send me a note. We'll do some listener feedback. Until next week, This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.